Greetings and welcome. Welcome to our Disparities Dialogue session for March. Delighted to announce that this month we'll be focusing on neuro-oncology. Also delighted to introduce our expert discussants for this month, both expertise in neuro-oncology, but even more so, both from New York. So wonderful to introduce them. So first we have Dr. Figueroa McFaline, who is a faculty member at New York University, NYU, and also to introduce Dr. Joshua Budhu, who is faculty at Memorial Sloan Kettering, again in New York. Welcome, both of you.
Thanks for having us.
Thank you. And so we'll start off in our first section by just giving you all a preview of the articles we hope to discuss today. So the very first article was published in JAMA Neurology earlier this year and focuses on the burden of CNS cancer in the US. The second paper we'll discuss today was published in the Journal of the National Cancer Institute and focuses on the important issue of disparities in the availability and access to neuro-oncology trialing support infrastructure in the US. We'll also take a look at cancer health disparities affecting glioblastoma survival in Canada. Our fourth article takes a look at the issue of the social determinants as they pertain to patient-reported outcomes, health literacy, access to care in patients who have primary brain tumors. And this comes from the All of Us research program and was published in the Journal of Neuro-Oncology in 2025. In a similar vein, the next two articles look at the important issue of financial toxicity. First, this one, published in the Journal of Neuro-Oncology last year, looks at it in the pediatric and adolescent neurosurgical oncology population. And then the last, but certainly not the least, a study we'll be taking a look at today looks at the issue of financial toxicity in patients who have glioblastoma, again, published in the Journal of Neuro-Oncology in 2025. So without further ado, we'll take a little bit more of a deeper dive into the 6 articles we have for this month's session. And we'll start off with Ricky kindly going over this paper published in JAMA Neurology. Thanks, Ricky.
Thanks so much. So yes, I'm Ricky McFaline-Figueroa. I'm at NYU. Pleasure to be here. And so the first paper that we'll be discussing was published in JAMA Neurology. It's entitled Burden of the Central Nervous System Cancer in the United States, 1990 to 2021. A publication sponsored by the Global Burden of Disease United States CNS Cancer group. So the study analyzed trends and disparities in primary brain and central nervous system tumors in cancers from the time frame of 1990 to 2021 using global burden of disease data. And so we know that CNS cancer is quite rare, but has a high burden of mortality, morbidity, and neurologic disability. And so part of what this work tries to achieve is to add temporal trends, state-level variations, and sociodemographic disparities to the incidence of CNS cancers, as well as to the associations with things like disability-adjusted life years and years of life lost. So they used 183 US registries and health records. They looked at both the incidence rates, the years lived with disability, the years of life lost, and disability adjustive life years, which is a combination of years of life lost and years lived with disability, trying to give a number to the burden, the toll, societal toll on survival in these patients. And they grouped the data through all 50 states and the District of Columbia, patients being identified by ICD-10 codes. And so they do two things. They publish the data in 2000, the rates for 2021, and look at how these different variables change over the period of 1990 to 2021. So in 2021, there were about 31,000 cases of CNS cancer in the United States, which translated to an age standardized incidence rate of 6.91 per 100,000. The disability adjusted life year rate for this year was 134 years for that those incident patients, and a mortality rate of 4.1 per 100,000. Now, since 1990, they found that the overall incidence of the age standardized incidence rate of CNS cancers remained essentially stable. But then there was a decrease in mortality rates as well as a decrease in the disability adjusted life years throughout the span, with the disability adjusted life years coming down by about 16% and the mortality rate coming down by about 8%. These changes were, particularly the disability adjusted life years, were really driven by a reduction in years of life lost, suggesting that patients have perhaps been doing better over time in this time period. However, they see that it's not one, the United States does not behave as one entity in this. They see a lot of geographic variation. So states in what they term the East, South, Central, and the West, North, Central division, so this includes Mississippi, Alabama, Kentucky, Kansas, and West Virginia, had persistently high disability adjusted life years and mortality rates compared to the rest of the country. The states that did the best in terms of mortality and disability adjusted life years were coastal cities, and these included DC, Hawaii, New York, New Jersey, and California. And interestingly, West Virginia was the only state that had a significant increase in both disability and mortality rate over this time span. They also find variation on sex, with males consistently having higher incidence of these tumors, as well as disability adjusted life years and mortality rates. The authors mention that this is contrary to some of the published data, but I think as most neuro-oncologists recognize that particularly the high-grade gliomas have a male over female predisposition, so it's not entirely novel. And this sex gap seems to be only in adult patients. Looking at the pediatric populations, there was no difference in incidence rates by age, by sex, sorry. The incidence of these tumors seems to have a bimodal distribution. It peaks first in young children under the age of 10, and then again in older adults. And this, again, kind of follows some of what we know of the epidemiology of these tumors. And looking at sociodemographic index as a marker of higher income, the higher the number, the higher the income of a state, higher education, lower young age fertility. This metric negatively correlated with incidence rates, so that high socio-demographic index was associated with lower mortality rates and lower disability adjusted life years. So basically saying more socioeconomically advantaged states had lower disability adjusted life years and mortality rates compared to the others. Again, this was mostly driven by a decrease in years of life lost. And sorry, this is all for disability and mortality rates. The incidence rates themselves do not seem to change much. And then there were some states, Mississippi, Alabama, Tennessee, that had a higher burden than you would expect for the trend of sociodemographic index, suggesting that there's additional factors that were not quite captured with that metric. Of course, there's a lot of limitations to a study like this. The data from the Global Burden of Disease databases varies a lot by state in both quality and completeness. It treats CNS cancers as one big behemoth by anatomic site rather than histology, so it's hard to know exactly which cancers we're looking at and if they're accurately capturing the cancers that we think of as CNS cancers, particularly the primary ones. And then there's no race or ethnicity data or other granular demographic data in this data set. So overall, it provides a state level overview of what the trends are in mortality rates and disability adjusted life years across the geography of the United States. This can support public health planning and policy for CNS cancers across the US. And it highlights persistent disparities in outcomes related to state, age, sex, and importantly, socio-demographic index within certain regions. And finally, the implications that I think the take-home messages of a paper like this would be that geography and socioeconomic context in the United States seems to be key drivers of inequities, with low SDI states experiencing worse disability-adjusted life years and mortality outcomes, even though the incidence is similar. And gives a roadmap of how one might redistribute resources and access throughout the geography of the United States.
Oh, thanks so much, Rick. It's fascinating because in stroke, we also have what we call the stroke belt, where we have these states in the southeastern US that have higher mortality compared to the rest of the country. And again, not unlike this study, some of it is socioeconomic, but there also seems to be some other factors that are contributing to this higher burden. You very helpfully explain the issue of these disparities in these states. But I did want to ask you, in your experience and expertise as a neuro-oncologist, do these data from the global burden, where we talk about these states and these population groups and the relationship to the SDI, does that align with the rest of the literature and your experience, or is this surprising in any way?
I think so certainly the data on socio-demographic index does align with the rest of the literature. I mean, I think there's a clear relationship throughout on outcomes being better and this is true of all cancers, I think, not just neuro-oncology, but outcomes being better for populations that have, higher income, higher education. I think it doesn't capture fully exactly what's happening in those states. A lot of it has to do with, again, the lack of very granular data on both the cancers, because not all cancers made equal. And then, again, I think the lack of particularly race and ethnicity data really kind of leaves a lot of gaps in terms of what the data shows.
Yeah, no, and the other thought that came to my mind was so clearly incidence has remained the same, but mortality and DALYs have dropped. Now, again, sorry to talk about stroke again, but that's most of what I know. We see a similar thing in stroke, but we also see a decrease in incidence as well. And we attribute the improvement in terms of mortality to better treatments. And so my first question to you as an expert in this area is, why are we not seeing a drop in incidence? Why are we not preventing these type of cancers more? I would have loved to see that, but maybe I'm being too optimistic about that. Your thoughts?
So based on the kind of ICD-10 codes that they picked for this study, I mean, it's going to have more of a skew towards, for example, gliomas and other primary brain tumors. And that 1990 to 2021 range, which is quite large, sees a lot of things like, for example, the approval of temozolomide for patients with glioblastoma, which the landmark study is from 2005. And so that is a treatment that for patients with a specific biomarker, MGMT promoter methylation, doubles survival in that, 30% of patients with that biomarker. And so that is, certainly there have been some very specific studies that you can pinpoint in that time frame that have been helpful to survival. It's interesting to see that it's not all equal and that there's not only a trend for low SDI areas to have, a higher burden of these things that are clearly not seeing the same advantages, but then also, I'm not really sure what's happening in West Virginia, why everything else is going down and that one specifically is going up.
It's fascinating. Josh, any thoughts about this one?
Yeah, I think it's a really interesting study to look at, geographic location in different states. And, what the kind of first thing that pops out to me is the states that, had the, kind of the least burden, like in terms of dollies. And, if you look at DC, Hawaii, New York, these are usually the states actually with the lowest or highest rates of insurance, of health insurance.
Mm.
And, that might itself not just be the sole marker, but it also just might be a proxy of, how that the healthcare is run in that state, access to specialists and, just a bunch of other factors. So, I think we'd probably see or similar kind of disparities, as you mentioned from the stroke belt, but then also other parts of oncology as well.
That's fascinating. I'm still struck by the fact that it doesn't seem like if there was any disparity in incidence per se, but again, it seems as if it was really more in terms of access to care for these things based on insurance and other things. So that's fascinating. No, thank you so much, both of you, for that one. We'll move to the next paper, which is on disparities in the availability and access to neuro-onc trial supporting infrastructure. Thanks for helping us with this one, Ricky.
Sure. So this is a study from the Journal of the National Cancer Institute. So it's specifically looking at a couple of layers of clinical trial accessibility for patients across geographic terms, specifically not just clinical trial availability and availability of the providers required for clinical trials, for example, neuro-oncologists, but then also the availability of the infrastructure that you need to be able to complete successfully a clinical trial and have, everything that's required, because there's obviously lots of regulatory needs, lots of infrastructure that needs to be in place. And it's saying, it's specifically focusing on that as well. So it's really trying to give a more holistic view than just saying these are the trials available by zip code. And I will say that one limitation of this that will come later is that they focus specifically on government-sponsored collaboratives. This work does not really take into account the infrastructure that pharma has put together for clinical trials, and that's going to be, another layer that's not explored. So it uses publicly available data sets, identified 1,900 neuro-oncology clinical trials. It focuses on main member institutions of the National Clinical Trials Network, which is the arm of NCI that conducts clinical trials. Importantly, it also includes the National Cancer Institute for Community Oncology Research Program, and this is a program specifically for improving clinical trial access in the community, not just in, by community meaning, not necessarily their urban setting, not necessarily, where the big academic centers are. Training programs and, like I said, providers are also kind of analyzed, and they're analyzed by geospatial constraints, zip codes particularly, and then they link this to population counts in the zip code, and then things like area deprivation index, which is a composite measure of how disadvantaged a neighborhood might be in socioeconomic terms. And then they take all this data and they analyze they ask three questions. What is the availability by geographic area, by zip code? What is the abundance in any particular zip code or average abundance? And what is the utilization? How many sites are and from the infrastructure standpoint, so how many trial sites exist in a place with infrastructure, which is a little bit of a weird way to think about this. And then they use, kind of typical statistical techniques to try to draw significant correlations. So one thing that pops right up is the fact that clinical trial availability is sparse. So basically, infrastructure and trial sites are limited to 15% of all zip codes, which is quite a small number if you consider the number of zip codes. And translating, this with population size and both for the country and those zip codes leaves almost 60% of the US population in zip codes that do not have direct access to this trial supporting infrastructure or are not close to them. When you're looking, granularly at all the other things that they look at, it's even kind of more sparse. So, for example, NCT institutions, the clinical trial arm of the NCI, is only 2% of zip codes. The community organization focus program, NCORP, is only 2% of zip codes as well. Not surprisingly, most of the infrastructure is located in urban settings, so 71%. And looking at the deprivation index, area deprivation index, also most of them are in zip codes that have have lower ADI, so more advantaged zip codes. Its population size is also a big predictor of availability. Larger zip codes have many more trial sites, and that would be, in some ways, intuitive. In terms of, like I said, so a negative correlation with area deprivation index, so places that are disadvantaged by that measure seem to have noticeably less infrastructure and clinical trial sites. Among the ones that have infrastructure present, again, now when you look at the trial availability, it's again lower for those zip codes that are disadvantaged compared to the advantaged ones, both of them having infrastructure present. And then finally, so I'm just looking at my notes for my train of thoughts. There's some mismatch in potential. So if you look at the trial sites that are available by zip code that has infrastructure, it's not very even. Again, it's urban over rural, and this also, goes into the community settings, which, for example, is NCORP's mission. So NCORP infrastructure locations seem to have less trials compared to kind of other sites that don't have a community mission. So certainly this data is at the zip code level and misses a lot of other factors that are more granular than that. Like I mentioned before, it focuses only on government-sponsored collaboratives. It doesn't give you any data about individual enrollment numbers, for example. It just takes into account trial numbers that are open and infrastructure. It does show that the structure is very sparsely laid out. It's very urban-centric, and it's skewed towards socioeconomically advantaged areas. And again, gives a bit of a roadmap for things to do. I think particularly it's hard, it can be hard to address the infrastructure question, but certainly in the places that have infrastructure, the use in terms of trial availability seems to still be low in rural and high deprivation areas. And that's certainly something that can be worked on consciously now that you have the infrastructure there.
Oh, thanks for that, Ricky. Quite intriguing, I think. So clearly, over half the US population lacks direct access to neuro-oncology trial supporting infrastructure. One of the things you mentioned a couple of times during your overview of the paper was that this only covers government-sponsored research infrastructure. So my question for you and for Josh is, I would suspect that pharma is even worse, because I would imagine the government has the charge to try and, bolster access as much as possible. What is your experience? Are pharma trials is this disparity even more exacerbated?
So it's interesting. I mean, I don't know the hard numbers. I can tell you that it's going to depend on a few different factors. I mean, I think certainly you need much more infrastructure for early phase studies than you need for, phase 3 studies, which is a much more simple question, has much less monitoring, has endpoints that are more easily accessible to any site, even if there's not a big infrastructure supporting it. A lot of those trials will have pharma sponsors. I think that I would be curious to see this data based on phases of clinical trial. I think what's going to bear out is that places with infrastructure, particularly it's going to be urban areas, particularly it's going to be high population zip codes, highly advantaged. Those are, I think, where phase 1 and some phase 2 trials will concentrate. And I think essentially anything else that is in a community site or in a more disadvantaged site, if they're going to have something, I think there's intuitively it's going to be something like a phase 3 trial. So I'd be interested in seeing data broken down that way.
That's fascinating. I also wonder, if I may, because I always use this opportunity to learn about about areas that I'm not very familiar with, is any reason to believe that there might also be variation in terms of the type of CNS cancer, or does this seem to largely align in your experience with what might happen across different types of CNS cancers as well?
I guess I'll be honest, I don't know. And
Sure.
this paper doesn't really get into the granularity of what type of cancers we're dealing with, right? It just talks about clinical trials in general. I'm not sure. I'll say this. I think that availability of specialists who deal with primary brain tumors is much lower than availability of specialists who do metastatic disease of the brain. I think that strongly impacts, what can be done where, the access to expertise. And those, neuro-oncology availability actually was one of the things that significantly was inversely related to the deprivation index, for example.
That's great. Josh, any thoughts about this one?
Yeah, I guess for that previous question, also agree with Ricky, and also would think about, the rarer the CNS cancer, probably only a few centers would offer trials. So, um, for example, CNS lymphoma, one of the ones that we see only 12 to 1400 cases per year in the U.S. and it's hard to run a trial if you're only seeing 1 or 2 patients per year.
Right.
So that's where I think it would also kind of fall in. And this is kind of a plug for a position paper that Ricky and I worked on, but we looked at the ways to improve representation of CNS clinical trials, and infrastructure was a big part of it. And in terms of thinking about solutions, decentralized trials always come up as a way to try and improve access, but it really is tough given like geographic constraints. Patients with CNS tumors often have neurologic deficits that compound, travel. It's hard to spend hours per day or go to so many different visits. So it's a complex kind of problem, but this infrastructure is a big part of it. And as we think of solutions, they have to be multi-level, which helps address this, but then also thinks about the underlying patient and neurologic condition of them as well.
Yeah, great thoughts. And something that just came to my mind, which I'm not asking you to address, but because I work in the Veterans Administration system as well, I wonder how this all pans out and what that trial infrastructure might be. And but that's just a curiosity of mine, and I would love to explore how that looks. All right, move to the next paper, and this one looks to our neighbors to the north and looks at the issue of cancer health disparities affecting glioblastoma survival. So thank you, Ricky, again for guiding us through this one.
Sure. And this one is, the last 2 papers are really about kind of a macro view of a system where access to healthcare is highly, correlated to insurance access, meaning the U.S., as opposed to this paper where they're arguing, and it's true to some extent, maybe definitely not fully, but they're looking at a system where you're taking that kind of insurance variability out to some extent. So we're dealing with looking at cancer health disparities in glioblastoma survival in Ontario, Canada, which has a universal single-payer health system, right? And so within the confines of this group, which is, at least in terms of insurance, is more homogeneous, they asked the question through a retrospective study of which, do socioeconomic factors influence survival even in this population where, you would assume that most patients have access to care. And so they look at overall survival, certainly. They look at access to care in a couple of different metrics. One is, how many patients start adjuvant, meaning post surgery treatment within the 6 months after having their surgery. And they also look at another kind of proxy marker for establishing care, meaning specifically how many emergency department visits occur before their initial surgery. Are patients just not getting to that initial surgery when they should? So they ultimately identified 7,200 patients with a median survival of almost 9 months. They found that 82% received adjuvant therapy, which is radiation and chemo, within 6 months. But they do still see some variability according to the factors that they measured. So, for example, their measures of neighborhood deprivation, the higher those measures were, the worse the outcomes appeared to be. Patients in the most deprived areas had shorter median survivals and had higher hazards for, survival and cancer, both overall survival and cancer-specific death. They also had less chances of receiving adjuvant treatment within that 6-month time frame and appeared to have significantly more emergency department visits prior to surgery. In addition to kind of socioeconomic factors, they also look at immigration status and rurality. An interesting observation is that recent and remote immigrants had better overall and cancer-specific survival than non-immigrant in this zip codes. They attribute this in some extent to the population that is immigrating into Canada being more socioeconomically advantaged. Refugees did not have that advantage compared to non-immigrants, for example. Some caveats to that. Not everyone did well. Recent immigrants, for example, seem to have more difficulty establishing care in those 6 months after surgery. But in terms of survival, there was that trend. And then rural residents did not seem to predict survival or adjuvant treatment, but these patients did have more emergency room visits prior to the surgery. The limitations here, we're talking about survival, we're talking about glioblastoma. I mentioned earlier that MGMT promoter methylation is a huge prognostic factor because it has to do with what patients do, particularly in the setting of chemoradiation with chemotherapy added. None of that is looked at in this metric, and the socioeconomic measures are more areal level rather than individual. So it's interesting, just even in a system where you have universal public insurance and a publicly funded health system, you still have disparities in outcomes associated with deprivation indices in neighborhoods and geography that have to do with not only worse survival and worse access to care. And so, certainly it makes an argument that it's not just access to insurance, and there's other interventions that need to be done in order to bring both, deprived communities access to glioblastoma care. And then again, doesn't impact survival, but rural communities and getting timely access to treatment.
That's great. Thanks so much, Ricky. And again, it speaks to the question I raised at the end of the other one, which was, for instance, the VA is our only national healthcare system. And I wonder to what extent that's been studied within the US in terms of the VA system. But I was a little surprised that the explanation in terms of the immigrants was really that they were somewhat wealthier and that's what protected them. And that's not typically what I think of when I think of when immigrants, people are migrating for economic reasons. So that was a little bit of a curiosity for me. But Ricky, in your mind, beyond some of the factors they mentioned, what might put patients who come from these materially deprived neighborhoods at greater risk for having poorer survival with GBM and lower likelihood of receiving adjuvant therapy?
I think it's a complicated question. I think one thing that came to my mind as I was reading through the paper, particularly when you're talking about recent immigration and certainly refugees, which I do separately highlight, how many patients are not seen here, right? So how many patients fail to establish with the publicly funded health system, period, who are immigrants, who are not going to be captured in this analysis and not easily captured overall, right? So I think there's certainly a bias that comes from the fact that in order to be counted for this study, immigrants had to establish with the healthcare system to begin with, right? So I think that is one interesting thing to keep in mind as you're looking at this data. I don't know. I think I would be interesting. It would be great if they had access to, I don't know if they did, kind of immigration level data of their socioeconomic factors, for example, to see what else was skewing that. For now, I would just make an observation of it, but I think certainly the takeaway should not be, immigrants don't need targeted interventions because they do better. I think that's a dangerous idea to have. I think right now, at the level of this paper, it's just an interesting comment.
That's a great point, and it helps me a lot, Ricky. Thank you for that, because it makes sense to me now, based on what you said, that the wealth of the immigrants might also be tied to being better informed and better educated, which might lead them to be more likely to tap into the system and avail themselves of those things. While the people who really, they're not refugees necessarily, but are less socioeconomically advanced, so to speak, may be less likely, are not included in the denominator here. So again, I'm hypothesizing here and speculating, I don't know, but that finding, it's still trying to reconcile that to every extent that I can. With stroke, we do see a healthy immigrant hypothesis, so to speak, but it speaks more to the culture and the affinity of the community, so to speak, to rally around sick members, so to speak. And that's been proposed as the potential explanation that, just in terms of the support system might be contributing to the better outcomes that we sometimes see for stroke in these populations, or their lesser inclination to take on maybe some of the more seemingly Western style or high income lifestyle practices that might be a little bit deleterious. And so those are explanations in stroke, which are probably different from GBM. Josh, your thoughts, please, if any.
Yeah, it is interesting, like thinking about like the healthy immigrant paradox. And one, I would, initially I would assume that we wouldn't see that here in glioblastoma, but maybe actually, like you mentioned about social networks or support system could have a good effect. And um, there has been more interest in our field about exploring caregivers, social networks, what kind of support systems they have, and you know, I would actually be very interested to see, that there's also like, does the immune function correlate also with your social support network and a lot of these things, and what's happening in the tumor microenvironment and like stressors on the body and such. So I think there's a lot of interesting things that a lot of interesting questions, and carefully designed studies that are both translational and basic science and such can try to answer those. But it raises a lot of questions, and all, I think all of them good questions.
Yeah, if I may just ask a naive question again, I use this opportunity to learn. Have there been studies of navigators, community navigators, in terms of interventions, and whether those have any positive impact on survival or other things, as far as you both know? Or
Yeah, so there's been a few navigation studies. The most of them are actually the quality improvement projects,
ah,
and they haven't actually measured survival, but they measured a lot of other kind of proxies, such as time to referral, or to like a different subspecialist, or some patient-reported outcomes. But to be honest, there's only a few. There's actually we're looking at a trying to do like a scoping review of this, and there's not that many programs compared to the rest of oncology in which patient navigation has really taken off. So, definitely a field, an area for more study in neuro-oncology.
Thank you. All right. Let's move to the next article. This was an article published last year in the journal Neuro-Oncology, looking at socioeconomic disparities across a whole host of outcomes. And Josh is going to kindly take us through this one.
And so this is a study that used the All of Us database to really go through it and see, what are differences between or kind of disparities using socioeconomic deprivation index. So some of the background that we kind of have talked about, but and seen too from some of the studies that Ricky has gone over, there are some socioeconomic disparities, and these influence some outcomes in primary brain tumors. And what was interesting about the study is that they used the All of Us database, which is kind of a unique database. It's sponsored by the NIH, and the goal is to enroll about 1 million participants. And the really good focus about the All of Us database is that it purposely is trying to be representative. So, as opposed to some of our other databases in which usually they skew towards European ancestry. For example, this is purposely trying to enroll diverse diverse segments of the population so that we can answer different questions about whether proxies or if there's any difference in biology or so, and how people biology plus also social factors that can contribute to outcomes. So this study, they also used something that was a little bit different too. A lot of studies use AD, like Area Deprivation Index. This one, they used the Individual Socioeconomic Deprivation Index, which is similar but slightly different. It looks at education, employment, housing, insurance, income, and similar to how it's coded for Area Deprivation Index. The higher the score, the higher the socioeconomic deprivation. And in this study, they identified 873 patients with primary brain tumors, and they found that if you had greater socioeconomic deprivation, so I guess in a sense lower socioeconomic status, you had higher rates of fatigue, pain, emotional distress, poor general and mental health, reduced functional independence, and lower quality of life. So a lot of patient-reported outcomes, quality of life is very closely associated with this. What was kind of interesting was that access to care, such as delaying prescriptions, skipping medications due to cost, difficulty affording care or specialists, was not actually associated with having greater socioeconomic deprivation index. And also, one thing specifically too that they saw was that there was worse health literacy in comparing and looking at increased socioeconomic deprivation index. And that's one thing about the All of Us study, which is nice. It captures quite a few different aspects in the database, a lot of patient-reported outcomes, PROs, including like health literacy. So you can actually look at a lot of these different features with it. So I think, this is a good study in showing really, one of the things we've been looking at neuro-oncology a lot is quality of life measures, especially, as potentially we're having, new treatments, but looking at radiation, chemotherapy, a lot of the treatments we have can be quite toxic. So one of the kind of measures that we look for as well, besides just increasing survival or life expectancy, is whether, quality of life issues or quality of life measures will be improved. And I think this study kind of just shows us that, certain segments of the population, especially those who have, lower socioeconomic status, less access to finances, insurance, income, already at baseline potentially are going to be predisposed to worse outcomes for fatigue, emotional distress, and all of these. for this study, the limitations are that, it is a voluntary database. So people, are signing up for all of us. So it may not be, as generalizable to the entire population. That's kind of countered with, this is trying to be more representative. And also, uh, there's actually not as much information about the type of tumor as well. There is they do look at, gliomas and glioblastoma, but sometimes it's not coded, or it's kind of lumped together in different categories. Um, and because it's, even though currently the All of Us database, I think it has over 300,000 responses so far. For primary brain tumors, it's 800 patients. It's still pretty large, but it's not it's not a huge database. Um, so kind of looking towards potential implications or so. When we think about interventions, access to supportive care and palliative care and other quality of life measures and specialists, I think this is something that we can, it gives good evidence for us to try to prioritize, especially for populations that are socioeconomically deprived.
No, thank you so much, Josh, for that. And um, I think I was fascinated because clearly there were already data looking at hard outcomes like survival, but it was gratifying to see that this emphasized patient-reported outcomes as well. And to that point that you made about quality of life, I think is extremely important. So while, as you mentioned, there are limitations to this, clearly this is an advance in helping us to better understand, how patients feel about some of these things that might diminish their quality of life. I think one question, and you elaborated on the limitations quite well and alluded to some of the strengths, including representation and literacy. Are there other strengths to the use of the All of Us database in studying socioeconomic disparities in patients who have primary brain tumors that you might want to elaborate on?
Yeah, and I think the All of Us database, besides just primary brain tumors, just for neuro-oncology and also neurology in general, it can probably be a really powerful data set for us to use because, like I mentioned, it captures, besides patient-reported outcomes, there's also a lot of surveys and a lot of other data, such as environmental exposures and some genomic data that people can provide. And I think this will allow us to at least make some hypothesis or bridge the gap between, are there other risk factors for, developing, you know, types of neurologic disease? Are there epigenetic factors that might be also coming into play, both in terms of outcomes, yeah, or both in terms of predisposing to incidence or development of a disease? So I think to be honest, all of us it's a really great initiative, and I'm hoping they get to accrue to that million number because I think just having the ability to have a really purposely inclusive and representative data set just makes research a lot easier, and also we can draw conclusions a little bit that are hopefully a little bit clearer, especially in trying to connect, or when we think about there's a concept of the exposome. So not just thinking, or thinking about the multiple aspects of, social determinants of health, where environmental exposures, structural drivers, and how all of these, kind of come back into your own body, looking at DNA changes and the your underlying structure. And I think all of this is a great way to kind of maybe come to some of those answers.
No, point so well taken. And one other question I had for you, if I may, is you called out on the slide in the implications section how we should go about trying to address these socioeconomic disparities. And you called out, of course, education and supportive care. In your mind, were there any specific targeted interventions that you think might help address the disparities identified in this case?
Yeah, and I think I'll go back to one of the question you posed with Ricky, but I think honestly, patient navigation is a really good intervention to address these, and the reason being is that many people don't even understand what they, or don't know like what services potentially, we can offer. It may not be picked up by the clinical team, and you just might need someone to sit down, kind of ascertain different symptoms, figure out, what would actually be the most appropriate, and kind of just having someone not just navigate appointments, but thinking about, insurance issues, financial navigation, connecting with essential resources and needs. And all of these, when I think about fatigue and emotional distress, these are all exacerbated by if you have worried about which your next paycheck is coming from, or if you're worried about supporting your family, or like where's your income going to come from. This is where connecting to also broader resources and patient advocacy can help with that. So I think that's one of the interventions which I'd like to see continue to be implemented in neuro-oncology practice.
No, I agree. And one of the things I didn't see here called out as much was the intersection of race and the socioeconomic as well. In stroke, we've done a few surveys and it's been striking how the concerns about working and socioeconomic issues after a stroke has occurred seem to be highly disparate between non-Hispanic whites and non-Hispanic blacks. And again, not that it's not a concern necessarily for non-Hispanic whites, but we saw a huge disparity in terms of how much of a concern it was for non-Hispanic blacks. And I wonder to what extent in other neurological disease entities, those kind of factors play a role. Ricky, your thoughts, if any?
Just to echo, hugely important educational aspect. And I think it's difficult in a healthcare system that is driven by how many patients you see and see more and more and more, faster, faster, faster. These limitations of health literacy really mean, one very easy intervention is all of us to spend longer with those patients who need more time to understand what's going on and more explanation, but the system sometimes doesn't let us do that. So I think that's, education is a huge barrier here.
Yeah, and I saw Josh nodding his head forcefully to that. So yes, here. So thank you. We'll move to the next paper, which looks at the issue of financial toxicity in the peds and adolescent neurosurgical oncology population. This paper was published in the Journal of Neuro-Oncology last year, and Josh is going to guide us through it.
And thanks for that, Bruce. So financial toxicity, this is something that I study, so these papers are always near and dear to my heart. But financial toxicity is, you could kind of think about it in two components. It's both the direct economic strain, plus also the psychological stress that comes with the cost of healthcare, and particularly affects or it's worse in people with chronic illness such as cancer, a lot of neurologic disease as well that are chronic and require a lot of long-standing therapy. Also, those populations experience a lot of financial toxicity. And in this study, it looked really at the pediatric population, which I think was quite interesting because, especially in the oncology or broader oncology literature, it's mainly looking at adults and potentially like the patients themselves and caregivers. But the pediatric population, I think, represents a very distinct one because it's not just the patient, but also family, parents, extended support. That's all involved. And this study was a single center study. It was done actually here at MSK, and it was looking at patients who underwent neurosurgery. So they had some type of brain surgery for tumor resection or either biopsy. And the financial toxicity, there's a few ways we could define it. This one was retrospective, so they actually worked with the patient financial services to look at patients who were sent for collections, who needed financial assistance programs, were put on payment plans, and also look through social work documentation to see which patients potentially were kind of screened positive for financial toxicity. And in this in the study, they were able to identify 202 patients, and out of those 202 patients, 16% of them experienced financial toxicity within 2 years of undergoing neurosurgery. And after the first neurosurgery, the cumulative incidence increased to 19%. And patients who had preoperative financial toxicity, not surprisingly, also likely to have postoperative financial toxicity. And one kind of thing that they saw that was very interesting was that insurance status didn't seem to eliminate the risk. So whether you were on government insurance, such as Medicaid for children versus private insurance, there didn't really seem to be that much of a correlation uh, with it. Some of the limitations, of course, for this study is that it was a single center study. MSK is a comprehensive cancer center, so it also doesn't have an emergency department. So patients need to be referred or usually will have some type of insurance or need to be accepted to have treatment here. And the definition of financial toxicity, or the way that they categorized it, is a little bit different than some of the prospective work that's being done, in which it looks at something like a cost score, in which there's predefined questions that tries to get a sense of, or how severe the financial toxicity is, plus also assessing for something like health-related social needs such as food insecurity or transportation insecurity. And some of the kind of conclusions, which are kind of general for this, because it really just hasn't been looked at, is that financial toxicity also affects pediatric patients, pediatric neuro-oncology patients, and that potentially screening is going to be very important for this population. And as I think the kind of the biggest takeaway is that as we're looking at things about financial toxicity insurance, we also need to incorporate the pediatric population and not just separate it into adults, and kind of realize this is an issue that spans the entire continuum of age range.
No, it sounds like a very, very important contribution. And I think my first question, again, out of naivete, is so Josh, this was your own center. I know you're not a pediatric neuro-oncologist, but is there any reason but you are a financial toxicity expert, is there any reason to believe that this is any different beyond your center, your quaternary level center?
Yeah, so the incidence is probably going to be higher, to be honest. So we've done a lot of work seeing that our patients, maybe about 25% of them experience financial toxicity in the adult realm, compared to other national studies. That national studies usually around like 30 to 35, or sometimes even potentially higher. So my suspicion is that pediatric patients or pediatric neurosurgical patients uh, and neuro-oncology patients probably actually have higher rates of financial toxicity outside of our center, and that's just a sense too, because we don't have an emergency department. We don't really see too many uninsured patients because they usually get referred in, or they have like a specific type of cancer. So that in itself, while the study didn't see any kind of difference between public and private insurance, not really able to assess potentially uninsured patients. I will say uninsured patients for the pediatric population comes with an asterisk, because usually they'll be after the first kind of encounter, almost children are eligible for at least some type of insurance, usually depending on the state.
It's interesting because my first thought would be, well, financial toxicity, it affects just the parents of the child. But is there any reason to believe it affects the child in terms of the child's psychology, or even the child's own capacity to recover or quality of life?
Yeah, and I think that's a great question. And when I think about it, I kind of think about a household, and thinking about the two aspects we talked about. So one, the psychological stressors, and as a child, you know, you might see your parents worry about finances. Many children are aware of what's going on in the household. Oh, we're seeing that we might not be able to take a trip, or we're saving for something, or we might have to go without certain leisure activities because we need to put it towards care. And then the other kind of aspect about it is, that the direct kind of economic or financial strain. If you're seeing your parents might have to work, extra, work two jobs, not be able to take off time, and that as a child, you know, leads to I would assume a lot higher psychologic stressors, worrying about anxiety, thinking about this, and then also the kind of when we think about the other economic or the direct contributors to financial toxicity, thinking about the overall household too, because one parent might need to take a couple days off per week, depending on the type of treatment to come with the child to potentially to get chemotherapy or radiation, and that leads to lower income, and that also consequently leads to other things that may not be available for the child. And thinking about the entire spectrum, potentially not even what's going to happen for the current disease, but in a few years, would that also affect opportunities for that child to enroll in different activities, or just because of the income or wealth of that family has been affected. So I think there's a lot of things that can downstream effects that may be a little bit difficult to quantify, but I think are no less important.
Yeah. And I think the other surprise for me here, which you alluded to a little bit, was the issue of insurance did not necessarily eliminate the financial risk. And so just why might that be?
Yeah. So I think a good proportion is actually cost sharing. So with Medicaid programs, there's almost minimal or no cost sharing. So, parents, even though depending on the type of Medicaid that you're on, could be a little bit more restrictive, you at least are not paying a lot of out-of-pocket cost. Whereas for private insurance, there's copays, there's maximum out-of-pocket costs that can reach thousands of dollars. And that in itself is leads to a lot. I think for the U.S. as a system spends about $5 trillion on healthcare in total cost, and about depending on the year, about 10 to 14% of that is borne with direct out of cost. So you could think of that as it's $500 billion that people are paying out of pocket. And then also there's the added part of, most people or a decent amount of people with private insurance get it through their employer, which also, while the employer helps to pay, also that comes out of a paycheck as well. So I think, yeah, but to the answer for the question, I think cost sharing really, and kind of how those costs trickle down to families really is really important for that.
Thank you. Ricky, any thoughts, please?
The only thing I'll mention is just from personal experience, particularly seeing the young adults, adolescent populations, a lot of which kind of travel with their parents as well. The financial toxicity that stems from that poor geographic distribution of clinical trials and clinical trial access. You can have good insurance, you can get many things covered, but a lot of patients I find from this population will relocate for the few clinical trials that are available, and that's a huge financial toxicity too, in my experience, just anecdotally.
It's a great point. It's a great point. Thank you. Our last paper, by no means the least, looks at, again, financial toxicity, this time in patients with glioblastoma. So, Josh, if you may.
Yeah, I thought it'd be nice to close it out on a theme of financial toxicity. So this one was led by, or the senior author was Dr. Newman, who's a neurosurgeon, and also looking at financial toxicity, which we defined. But this one I thought was interesting because it was looking at a different population. It was looking at a center in Louisiana, and they went through their database and looked at bad debt. So basically, patients who were unable to pay, and kind of that went to collections. And what was, for me, that was kind of very, striking, was that it was a small study, but among the 74 patients, 44% experienced financial toxicity by that definition, going to collections. And uh, financial toxicity, the average amount of debt was about $7,500, and financial toxicity was associated with younger age, longer hospital length of stay, subtotal tumor resection. So maybe also some other kind of markers of potential maybe prognosis of disease in which we might think about, or other kind of comorbidities which can extend overall length of stay. And I thought this was a really interesting study too, because it just looked at a different population, whereas the previous study looked at a urban, tertiary, or actually quaternary cancer care center, and this one looked at it was a center that kind of took all comers. And the question we had before was about how many percentage of people have financial toxicity, and we actually don't have a lot of data on uh, neuro, or at least prospective data for neuro-oncology patients, both with and there's a little bit more for brain mets, but really for primary brain tumors, we don't have too much data. And this is one of the first studies that was able to kind of capture this. And I thought the definition was really quite interesting that they used. And again, another one in which it looked at patients who were going for craniotomy, so they had surgery. And I'd also be curious to see about the patients too who may not or have had surgery, but then also were followed longitudinally, getting chemotherapy, radiation, looking afterwards. Um, and they also kind of found in this study too, in terms of insurance coverage was also an aspect that was important. But I think kind of tying this in with the last study, uh, you know, I think kind of sets the stage for some of the future work that we need to be doing for neuro-oncology, which I think is building in prospective financial toxicity evaluations. So that's kind of using either the cost score or some of the other standardized metrics, and then trying to really not only understand the problem, but start working on interventions directly, because as we've seen from other parts of, or even looking at our own experiences, financial toxicity affects so many different aspects, and this is, I think, a thing that's very pressing in our field.
Well said, Josh. What structural features of glioblastoma care make patients particularly vulnerable to financial toxicity?
Yeah, and I think that's a really great point, because for standard upfront treatment for glioblastoma, we usually start with the surgery, trying to resect as much of the tumor as possible. But then standard of care is concurrent chemotherapy and radiation. And the radiation phase usually is 30 fractions of radiation. So that's 30 days that people go to the hospital, to the radiation oncology site, back and forth. And there's also been some interesting studies in oncology looking at the cost of parking, and about how all of these different aspects, even like cafeteria cost, how they all kind of add to the overall cost of treatment back and forth. And at some centers that don't subsidize parking across the country, 30 days could actually be almost like $1,000 in terms of parking, depending on the city. And it's worse in urban areas, in which I guess one of the ways that rural populations, at least with parking lots, are a little bit cheaper, but in urban areas, it can be very cost prohibitive to kind of park your car. So that kind of intense 30-day feature, or upfront treatment, I think is a big factor. The other parts, which we alluded to before, is just also the underlying neurologic deficits that patients with glioblastoma face. So many patients will try to work, or and uh, but because of either structural issues, or their own neurologic symptoms, may not be able to kind of maintain employment, and also because of the overall lifespan. We've also seen that patients, it's a little bit sometimes harder to kind of get all the application in for disability, to kind of get other benefits, or really experience it for a maximum amount of time, because that paperwork does take time. And if your overall life expectancy can be months, it may be a delay in which you're not able to experience some of the public benefits.
Interesting. And the type of financial toxicity in glioblastoma, is it mainly a healthcare system issue or a broader societal socioeconomic problem?
I think, to be honest, it's probably both. So, our healthcare system, you know, as we also mentioned before, insurance coverage is very highly variable, the way that it's one paid for and administered. So, the VA system is national system, but when we think about the other parts of the government pays for Medicare, Medicaid, that's almost or a little bit more than half of the population in the US. And then there's the segments of private insurance, which can range widely in types of coverage. And healthcare costs are a huge factor. Prices are opaque, they're not transparent, and there's a lot of cost sharing and out-of-pocket costs that falls down to patients just because of our system is designed. And then I think also the broader socioeconomic issue is, uh, when we just talk too about disparities in general and, where money is going for, one of the cases I make for addressing disparities is that, if we can alleviate pre-morbid or, uh, eliminate some of these like earlier mortality, morbidity, we're actually saving money because it's not going to the healthcare system. People are able to live longer, they're able to contribute to society. And financial toxicity is just another way of that too, because depending on where kind of people's like finances or so are going, it kind of links back to where else can that be better spent? And that's where it becomes both also a broader societal socioeconomic issue.
Thank you. Ricky, any additional thoughts, please?
Just agree with the neurologic compromise, probably part of what goes with that subtotal tumor resection, longer hospital stay association, the costs required of being more disabled with any of these diseases, but home care, be it, family members having to stay home to help in care, lots of little things that add up quickly.
That's great. And I know, Josh, you want to teach us some more using this model of yours.
Yeah. So this is from a paper that we recently published, but we put financial toxicity into a social ecological model in which we looked at different aspects of both the drivers of disparities, but also potential interventions we could think about. And I think it's important to understand a lot of the either disparities that we're talking about, looking at it in different lenses and a framework. So, when we think initially of like financial toxicity, we think about the individual level all the way at the bottom of that, where we're looking at high out-of-pocket cost. But, going back to that previous question about the societal issues, if you look at the top, we see healthcare pricing, insurance costs shifting, medical debt. And when we think about also our community, organizational, interpersonal, all the different levels that someone interacts with the healthcare system, we think about geographic barriers, travel burdens for the community, area deprivation, which has been talked about quite a lot in the studies we've looked at before, and then the organizational part about the healthcare system, time toxicity, scheduling issues, which we sometimes just say someone has to come see us on this certain day, or even thinking about the radiation schedules and such, where that can cause a lot of undue stress, causing people to take days off from work. And compensation may be tied to that, especially if you don't have paid time off. And for interventions, I think this kind of was a model like this helps guide us, because it takes a little bit of the onus out of just looking at the individual level. Because if we are thinking about intervention just at that, we would give education to someone about how to manage your finances and help with financial literacy, which by itself is important, but it can't really address the problem of cost sharing. So if you are very financially savvy, but you just your job doesn't pay you that much, you're going to have to pay some out-of-pocket cost, and that's something that's just going to be unavoidable. So when we think about that and kind of pairing financial literacy or financial navigation interventions, we really also need to be thinking about from the healthcare policy perspective about, do we need to improve our health coverage system? Does the US, can we work towards universal health coverage? As institutions and hospitals, do we think about, embedding financial toxicity screening? What types of navigation can we offer to people, and what kind of resources can we offer to people? And then thinking about, as physicians, as APPs, nurses, all parts of the medical system, how can we also make it more comfortable for patients to talk about these issues, and so that we can refer them to the resources that we have?
Absolutely fantastic. I think it's a wonderful way for us to end this particular superb session, inaugural session on neuro-oncology. Just want to express my profound appreciation to Dr. Figueroa, McFaline, and Dr. Budhu for teaching us, for guiding us, and for, I think, providing some great fodder for future research in this area. So thank you both so much for lending your expertise and experience to our knowledge base. I want to remind all our viewers and audience for Disparities Dialogue that the broader SEQUINS Society has its meeting on May the 14th. We look forward to you joining us in person or virtually. It's going to be a great conference, and we have, for the first time, abstracts being presented at the conference. I want to remind you that we also have a scientific journal, Equity Neuroscience, and so we look forward to you submitting your work to Equity Neuroscience, and also kindly considering to serve as reviewers for the journal. And then finally, we have our monthly podcast, No Brain Behind, which is highly subscribed, and which is a way in which we're able to feature the experts, both lay experts and also scientific experts, talking about how we can best bridge the issue of neurological disparities and trying to enhance brain health equity worldwide. Again, thank you all so much, and we're looking forward to next month's edition of Disparities Dialogue.